Barbara Siuksniute, doctor. Please welcome. And the topic is about prostate biopsies during COVID time. So it's very actual in nowadays. So please.
Thank you very much. So, hello everyone. My name is Barbara, and I'm a resident doctor in urology. And today we will talk about the prostate biopsies in National Cancer Institute during the COVID-19 pandemics and what has changed. So, a little bit about the prostate cancer in the world. Prostate cancer is the second most common cancer in the world among men. The incidence in 2012 was around even over 1 million cases per year, which counted around 15% of all malignancies in the world. And the mortality is around 300,000 per year, which is around 6.6% of all mortality from malignancies in the world. So prostate cancer early diagnosis program. The program is being used for the prevention of prostate cancer in men from 50 to 69 years of age, as well as in men over 45 years who has a family history of prostate cancer from their fathers or brothers. Prostate cancer early detection and PSA diagnosis is provided in no more than once every 2 years, except of cases in men under 59 years of age who has a PSA level less than 1 nanogram per milliliter. In this case, PSA PSA testing is reimbursed only once every 5 years. In cases where men are over 60 years of age and has a PSA level under 2 nanograms per milliliter, again, the PSA testing is provided and reimbursed only once every 5 years. In Lithuania, we have started the early diagnosis program from 2006. However, clinically significant cases of prostate cancer that do not require treatment but are still being treated is probably the weakness of this program in Lithuania, and I will talk a little bit more about this. So what is clinically significant prostate cancer? First of all is the tumor volume. If the tumor volume is over 0.5 cubic centimeters, if the degree of differentiation according to Gleason score is over 7, in this case Gleason 7 4+3, and the tumor size can be of any size. Also, if the Gleason score is 7 3+4, the tumor should be longer than 4 millimeters in a prostate biopsy. All these three cases define the significant prostate cancer. Early diagnosis of prostate cancer, again, so digital rectal examination is widely used. Serum PSA level should be more than 3 nanograms per milliliter. Transrectal prostate biopsies is done. This testing is done from 8 to 12 cores, depending on the patient. Digital rectal examination, why is it so important, is really widely used and is one of the most significant studies of in the diagnosis of the prostate cancer. Because even if the PSA level is normal, but we find differences or abnormalities on digital rectal examination, it is the independent prognostic factor suggesting clinically significant prostate cancer. The sensitivity and specificity of digital rectal examination is 81 and 40% respectively, with a positive prognostic value of 42%. So the meaning of PSA. Extensive use of the PSA testing has improved the early diagnosis of the prostate cancer for sure. However, the study has low specificity, and due to the low specificity of PSA, too many patients with significant, clinically insignificant, prostate cancer are identified and are being treated. So here in this table, you can see that the higher PSA level would show the higher risk of prostate cancer and the higher Gleason score. So, for example, in the PSA level between 3 and 4, we would have a prostate cancer risk around 27%, and it is around 7% probability that we have a Gleason score of 7 or more. So transrectal biopsies. Transrectal biopsy is used with the transrectal ultrasound that can cause in about 30% of false negative prostate biopsies. In 1/3 of the patients, transrectal ultrasound biopsies do not reflect the volume of the tumor in the prostate gland or the degree of malignancy. Due to technical features, transrectal ultrasound biopsies do not sample the anterior and central part of the prostate gland. So, a small summary of all the biopsies performed in National Cancer Institute between 2010 and 2016. What we see here is that more and more transperineal biopsies are being done, and we will speak why. Here also the summary of all the biopsies done between 2019 and 2020, and what has happened, what has changed since the COVID-19 has arrived into the country. So we can see that in total, all the biopsies in 2019, we have performed around 900 biopsies, whereas in 2020, the number dropped drastically to 400. Why is that? Because patients do not get the appointments to doctors. They are not tested for the PSA level. They get sick. Their prostate biopsies are postponed. So all the prostate biopsies at National Cancer Institute. So first transrectal prostate biopsy was done in 1985. First transperineal biopsy was done in 2013. Cognitive prostate biopsies in 2016. MRI fusion using Biojet in 2018. And the newest, we're proud to say that MRI-guided prostate biopsy in bore was started this year in 2022. Prostate multiparametric MRI indications. So why is it used? First of all, for the detection or exclusion of the prostate cancer. So when we have a clinical suspicion of a prostate tumor lesion with increased PSA level, with abnormal digital rectal examination, we can do multiparametric MRI prior to biopsy. Also, we can use multiparametric MRI after a negative biopsy when we have a clinical suspicion of prostate tumor. Also, multiparametric MRI is used for assessment of the prevalence of local prostate cancer. According to the guidelines in UK, which were released in 2008, cancer staging is the only indication for MRI after a positive prostate biopsy. I guess the radiologist could introduce PIRADS score a little bit more, but from urology point of view, so PIRADS score 1 and 2, biopsy is not recommended. If we have PIRADS 3 on MRI, biopsy is not required, but may be performed if we suspect the tumor. So, for example, in the elevation of the PSA on abnormal digital rectal examination or other clinical data. PIRADS 4 and 5 could show a significant tumor, therefore the biopsy should be done. So a little bit, as I said, about the transperineal biopsies of the prostate. Why is it done and why is it continuing to grow? Because of the low risk of infections, the diagnostic value is around 85-90%. Biopsy material can be taken from any part of the prostate. Adaptive prostate biopsies can be performed according to lesions seen on the multiparametric MRI and 3D ultrasound. And Vezelis compared the diagnostic accuracy of transrectal ultrasound and transperineal biopsies after examining 124 patients who required repeated biopsy. So the study showed that around between 70 and 80% of clinically significant prostate cancer cases would not be detected if the biopsy was repeated using, again, transrectal ultrasound. Pictures from transperineal prostate biopsy. We can see a patient in lithotomic position using the grid, and as well here is the mapping of the modified Vezelis zones. This map is used for all the transperineal biopsies in National Cancer Institute. So prostate is divided into the apex, base, anterior and posterior parts. Here we see a transperineal biopsy using a fusion technique with biojet. Here the prostate is mapped and focal biopsy will be taken. Whereas here, again, transperineal prostate biopsy will be done with targeted and systemic transperineal biopsies. So what has changed the pandemic that is never ending? At first we had the guidelines given to the doctors here that if we have a digital rectal examination which is negative and PSA level lower than 10 nanograms per milliliter, MRI followed by biopsy, or we can postpone the biopsy after the pandemic or for 6 months. If we have a digital rectal examination abnormal and or PSA level which is higher than 10 nanograms per milliliter, MRI should be followed by biopsy. If the progression or metastasis is unlikely, it may be delayed for 6 months or until the end of the pandemic. Also, the biopsy could be done without MRI, and if the progression or metastasis is probable with a delay of 3 to 4 months, the diagnosis should be done by the end of a 3rd month. Biopsy without MRI, if the diagnosis is locally advanced or highly symptomatic. If the progression, metastasis, or death is likely with a delay of 6 weeks, the diagnosis cannot be done after 6 weeks, so we should diagnose it as soon as possible. Also, the symptomatic cases caused by metastasis, so CT or scintigraphy, For stage determination, biopsy may be delayed if the progression, metastasis, or death is likely within the delay of 6 weeks. The diagnosis should be done by the end of 6 weeks. And of course, imminent spinal cord compression, there may be no delays. The emergency treatment by 24 hours is required. So this is it from me, and thank you for your attention. And if you have any questions, I would be happy to answer.
Thank you for the presentation. We have one question from virtual audience. So, Alexander, I would like to ask about what is the evidence to call cancer 0.5 milliliter clinical significant?
So all the data was taken from the guidelines, and that's all.
So we see indications to call these clinical significant cancers from EU guidelines.
Yes. It has. Yeah.
Any questions? More questions?